Welcome everyone, and thank you for joining us. My name is Scott Drummond, and I am the Program Manager at VADA and MC for today. May I introduce Julia Daly from VADA as well, who we can thank for organising everything and who will be supporting us today. May I start by acknowledging the lands we are all coming from, the lands of the First Nations people, and pay my and our respects to Aboriginal elders past, present and emerging, and Aboriginal people joining us today. Welcome to this two-part webinar featuring two diverse presentations from two experts in their fields, Professor Ed Ogden and Cameron Francis. Welcome Ed, and Cameron will join us in the break. He's not with us right now. Ed will be leading us off with his presentation titled, Do You Recognise This Syndrome? ADHD in Childhood, Drug Use in Adolescence and Drug-Induced Psychosis. What's the risk? What's the treatment? We'll take a break between the sessions to get a cup of tea or a quick bite to eat, and then Cameron will conclude the winter webinar with a presentation on novel psychoactive substances. Really looking forward to both. Our presenters, Julia and I, will monitor any questions coming in, and I know the presenters are flexible about how they answer these, and Ed, in fact, I think has a couple of spots in his presentation where he's open and keen to hear questions. These webinars will be recorded and posted on VADA's YouTube channel for anyone wanting to watch later. It is my pleasure then to welcome Professor Ed Ogden. Professor Ogden obtained his degrees from the University of Melbourne. After spending his junior years at Box Hill Hospital, he entered general practice. In 1979, he was appointed as part-time police surgeon, assisting police with the examination of victims of crime, the healthcare of prisoners in police custody and giving evidence in court. In 1988, he moved into Russell Street Police Headquarters, practicing forensic medicine full-time. He remained with Victoria Police in various roles until 2012. He has spent many years as a visiting medical practitioner within the juvenile detention system as well. In 1994, together with his wife Jackie, he established Forensic Medical Consultants and providing impartial expert opinions in clinical forensic medicine with a particular emphasis on the effects of AOD on human behaviour. He is an addiction medicine specialist at St Vincent's Hospital, Melbourne, and Goulburn Valley Health in Shepparton. He is also Deputy Director, Addiction and Forensic Medicine at the Centre for Human Psychopharmacology, Swinburne Uni. His particular research interests focus on the role of AOD in traffic safety and the development of new AOD treatments. He's a Fellow of the Royal Australian College of General Practitioners, the RACGP, Fellow of the Chapter of Addiction Medicine of the Royal Australian College of Physicians, and a Fellow of the Faculty of Clinical Forensic Medicine of the Royal College of Pathologists of Australasia, and was awarded a Public Service Medal for services to clinical forensic medicine on Australia Day in 2005. That is an amazing CV, Ed, and we are privileged to have you with us. So thank you, and it is my pleasure to hand over to you.
Thanks, Scott. Do my best to share the screen correctly. Okay, so I wanted to introduce a slightly different perspective on AOD issues from the one that most of us are usually presented with. And so I've chosen to call this young lady Laura, and I'd be interested to hear comments on how often you've met someone like Laura. So what we're going to do today is to talk a little bit about Laura and then think about the degree to which the problems she has might be common. Tell you a little bit about ADHD and drug use, and then we'll think a little bit about what you'd do if you met Laura. So let me say that Laura is entirely based upon two patients of mine. I've merged a couple of things to make the story round out a little better. Laura is currently 24. She grew up in a little country town and went to a two-teacher primary school, which meant she got a lot of really individual support as a youngster, and then helped her maneuver her way through the difficulties of primary school. She describes herself, and her school reports described her as a chatterbox and a daydreamer. She remembers constantly being told to stop talking or to pay attention. As she got older, she had to go to high school in a nearby larger town, and she found secondary school very stressful. She found the classroom a very stressful environment. She couldn't concentrate. She was always daydreaming. She described being more interested in the birds in the trees or the flowers in the garden than what was being said in the classroom. She survived high school because she is very tall with long legs and a very charismatic personality. So everybody loved her. And she was really good at athletics. She could run fast, she could hurdle, she could high jump, and because of her height, she was the captain of the age basketball team most years. But the stresses of being at school increasingly were annoying, and she started smoking cannabis in her mid-teens. And joined a group of like-minded kids who were smoking more and more dope. As school became more and more difficult, and she found it difficult to control her busy brain, she spent more and more time daydreaming and getting high on cannabis. She found that being stoned just made the busy brain settle down. And she spent more and more time hanging around with pot smokers. So that by the time she was 16, she was a dropout from school, and she was increasingly aware of unusual thoughts that didn't quite make sense to her. As her teens went on, she had several episodes of psychosis. Initially took her to the family GP and then eventually ends up with a hospital admission with a psychotic illness. Along the way, she saw various mental health professionals and ends up with a grab bag of diagnoses, including drug-induced psychosis, borderline personality disorder. Questions were raised about whether she had bipolar disorder. And with one of her more bizarre psychotic admissions, there was a question raised as whether in fact she was a schizophrenic. And I guess the question I'd be interested in how often do people see someone like Laura? This is Laura's experience of being at school. I really like this cartoon because showing it to people is almost entirely diagnostic. If you show that to people where ADHD is a possible diagnosis, they just smile and say, that's me. If you show it to people where ADHD is not the diagnosis, they have no idea what's going on. They think it's really busy and chaotic. I had one guy last week who said, I have no idea what that is. Let me read all those things. What do they mean? I don't understand. Whereas I showed this to someone who could almost have been a Laura 2 or 3 weeks ago, and she was so excited by it that she demanded that I print it out, and she now has that in colour laminated on her bedroom wall. So let me tell you a bit more about Laura. She says that her brain is very busy. She's easily distracted by noise, by people talking, by anything in the environment. She has difficulty paying attention to what's going on. And even if you speak to her directly and explain something to her, she can't remember what you said. She has this constant feeling of being disorganized and overwhelmed, unless it's what she wants to do. And if it's something that really interests her, then she can hyper-focus. She can spend more time and more energy on it than most people. And it may explain some of the success she had on the sporting field, where when she was really into what was going on, she was better than everyone else. And so she describes this experience of sometimes feeling incredibly bright and and very clever, and at other times feeling lazy and stupid. And of course, over the years, she's had plenty of people tell her that she's lazy and stupid because she hasn't done things on time, she hasn't met expectations, she's lost things, she's forgotten things. Part of the ADHD syndrome is dysregulation of movement. So Laura always feels restless, she fidgets. I spoke to another Laura just before I got ready for this presentation, and while she was waiting for me, she destroyed the fob that let her into her car, and she came into the consultation with a handful of parts, saying, I was just getting restless waiting for you. You'll recognise Laura because she doesn't sit still. Particularly boys experience the sense of being driven by a motor. A lot of girls will describe their experience as being very talkative. Boys particularly tell you that they just can't sit still. They only feel okay when they're moving. And this is often really irritating to people. I guess it explains why ADHD was originally a diagnosis of boys under the age of 7, because they were the ones who were standing on the teacher's desk. And it took a while to recognise that ADHD occurs in girls, because girls don't tend to be quite so hyperactive. Girls tend to be daydreamers. The third part of the ADHD syndrome is dysregulation of impulse. People with ADHD are impulsive. They have difficulty waiting in turn. They interrupt. You can imagine having this child in your class interrupting, blurting things out, impulsively making decisions, throwing things around the classroom. And the response of institutions is not always positive. I interviewed a young man a few weeks ago who told me that his experience of primary school was that for 3 years, because he disrupted classes so much, they put a desk in the cleaner's closet for him. And when he disrupted the class, he got to go and sit in the cleaner's closet. Dysregulation of emotion is not part of the official diagnosis of ADHD. And it's partly because emotional dysregulation occurs in many other clinical situations. But it certainly is a feature of ADHD, and often the emotional response to things is out of proportion to the trigger. People with ADHD have difficulty managing their emotional responses. And so Laura has expressed extremes of anger and impatience and rage, very sensitive to being rejected, and this constant sense of not feeling okay, dysphoria. Very, very commonly, because of this difficulty being like everyone else, there's a social anxiety and panic. When you first meet Laura, she won't talk to you about her eating. But if you ask, you find that she has binge eating disorder, which sometimes alternates with bulimia or periods of anorexia. That again, there's a dysregulation of her relationship with food. So as a 15-year-old, Laura is suffering, and she discovers that cannabis relieves the tension. It helps her sleep. But coming from a good family, she has this sense of shame and failure. And the increasing use of cannabis is associated with a downward trend in her mental health. So at the age of 19, Laura has her first admission to a psychiatric unit with drug-induced psychosis. And the family are told that she has either drug-induced psychosis or this is an early manifestation of a longer-term psychotic illness like schizophrenia. She's prescribed olanzapine, which certainly slows down her abnormal thoughts, but she finds the sedation is overwhelming, and although it slows some of the psychotic thinking, it actually increases her sense of confusion because she no longer understands what's going on in her head. There's a lot going on, but she can't control it. And she gets really upset that olanzapine causes weight gain. So she gives up taking antipsychotics and goes back to cannabis as a way of managing. And this is the point at which you meet her. She has a second admission for drug-induced psychosis, and the mental health team refer her for AOD counselling. And if we were all in the same room, this would be the point at which I would be really interested to hear how people would approach this lady. I'm happy to pause for a moment and have a look at the chat and see if I'm missing something important. It's interesting that there's some comments about people being diagnosed late with ADHD and the suggestion that ADHD medication might be useful. The difficulty, of course, we have, and counselling, I love that. The difficulty we have, of course, is how many people are prepared to treat ADHD in patients who use drugs. I've had referrals from incredibly competent colleagues who don't feel comfortable dealing with ADHD in patients who use drugs. In fact, if you look at the way in which the Drugs and Poisons Regulation Group look at permits for psychostimulants, they actually are quite happy to give permits for people who use psychostimulants, as long as, if you look at the current permit process, one of the questions was, is this patient addicted to drugs? And if the patient is a drug user, it causes significant anxiety in the system, and often they require more evidence before they'll allow access to treatment. In the middle of last year, I had a referral, or it was a phone call from a very well-respected developmental paediatrician who said, look, I've got this 16-year-old girl, could have been Laura, got this 16-year-old girl who quite clearly has ADHD, but I can't treat her because she smokes cannabis. And my response to the paediatrician was, it's actually the other way around. If you treat her ADHD, she'll stop smoking cannabis, which she did. We had a young person referred to us in Shepparton a year or so back, smoking 7 grams of cannabis a day. And with a history not unlike Laura's. He had had several admissions to psychiatric units for drug-induced psychosis. And so I introduced the treatment of ADHD in consultation with the psychiatric team. And within a couple of weeks of starting treatment for ADHD, stopped smoking cannabis completely, which I found really interesting because getting people to stop smoking from 7 grams a day is a bit of a challenge. So back to Laura. Laura comes from a successful, she has family. Family is together. Dad's an electrician. Mum's a receptionist, a real estate office. Her siblings are very successful. Older brother is a builder and captain of the local country football team. Her younger brother is at university studying law and doing well. And the family regard Laura as having been their challenging child, always a chatterbox, never silent, loved sport, was always happy when she was moving, always popular at school. As I suggested to you earlier, Laura dropped out of school because it was too hard. Her brain was racing, too many thoughts. She was always daydreaming. And the only thing that seemed to help was cannabis, but that wasn't obviously helping her mental state. And when we show this to Laura, she goes, yes, this is me. This is my brain. And so one of the things that we can do is to start accumulating evidence about whether or not this could be ADHD. The adult self-report scale is freely available on the internet. It's a World Health Organization standard form. The first 6 questions, which are on the screen at the moment, really encapsulate the main parts of the ADHD syndrome. Difficulty finishing things because we're distracted, difficulty getting organized, difficulty starting or finishing tasks, inability to sit still, and this feeling of having to be moving all the time. The next 12 questions of the ASRS really just provide a bit more data. The best diagnostic tool is in fact a tool called the DIVA, but that takes about an hour and a half to do, and it's really the same questions. There are similar questionnaires which can be filled out by parents or significant others, particularly people who knew Laura when she was young. And you can see this, if I go back to this one, you can see all the ticks are on the right-hand side of the scale down here. And although it doesn't show very well on my screen, this is actually greyed out down here, and ticks in the grey are suggestive of ADHD. There are scales for, as I say, for parents and teachers. And again, you can see most of the ticks are to the right-hand side of the screen. This is not diagnostic by any means, but it is suggestive, and it's a really good basis for those of you who are not psychiatrists or psychologists. It really provides a nice basis for you to make a referral to the appropriate professional. So a couple of fast facts. The current evidence is that 7% of children have ADHD. About a third of them adjust as they get older. They learn tricks to cope with the fact that they have a neuroatypical brain. Some of them choose professions or careers that keep them so busy it's not a problem. But you're left with 60% of people who have difficulty living with their neuroatypical brain. So that leaves you with somewhere between 2 and 4% of the adult population with ADHD. The best figure for Australia is 3.8% of adults have ADHD, and the vast majority are untreated. So we pointed out some of the difficulties of ADHD. I don't for a moment want to say that ADHD is just bad. ADHD comes with lots of positive personal attributes. I love my ADHD patients. They are all of the things on the right-hand side, particularly the warm-hearted, generous, passionate. They're fun to work with, particularly once they understand that they've got someone who understands them. Some lovely stuff in the chat box, which I'm going to come back to. So the ADHD brain is busy. Imagine that you're trying to listen to me while you've got children yanking at your arm and calling your name, and someone's brewing coffee, and the radio's on and it's changing channels, and it's really hard to concentrate on what you're reading. And whilst all this is happening, I want you to listen to me. And whilst that's an exaggeration, it gives you a bit of an idea of what it's like living with an ADHD brain. Without wanting to go too much into the neuropsychology of this, since I do have a professional appointment in neuropsychology, I have to mention some. So here's a nerve cell that wants to coordinate a message with the next nerve cell. So a message goes down the nerve fiber, gets to the end of the nerve where it sprays a little bit of neurotransmitter, in this case dopamine, into the gap between the two nerves, and the chemical zaps across the gap and interacts with the next nerve. And then little pumps on the original nerve suck the dopamine back up, and that turns the message off. This happens incredibly quickly. The nerve to muscle junction is very similar, and so it's how we move, different transmitter. And what we think in ADHD is there are just more of these pumps, things that look like Pac-Man. And what they do is to take the dopamine up faster than normal, so that not much of it gets across, and we have a weak signal. And that, in a snapshot, is the neurobiology of ADHD. Weak signals in the dopamine system. And dopamine is partially responsible for organizing filtration in the brain, stopping unnecessary messages. We all have too much information available to us all the time. If I suggest you think about your shoes and socks or your underwear, I will be able to distract you by thinking about information that you normally ignore. Imagine if all that information was coming to you all the time. So all of the things that treat ADHD to some extent block the abnormal pumps so that there is more dopamine available in the gap between the nerves and the signal is better. So having an ADHD brain is like having a radio that's not properly tuned, and you're trying to hear a song, but there's static and there's other channels, and it's really hard to understand what you've got. And treating ADHD, provides some help. The cannabinoids and things like that, antidepressants, which increase serotonin, act like a mute button. They'll turn the noise down, but it doesn't mean that you can hear. It's just not as noisy. And being able to regulate ADHD allows the radio station to tune. So how common is this in our population? Well, there are many studies which show that something up to 40% of people with AOD issues may have ADHD. And that part of the reason that they're using substances is that they're self-medicating with things which will slow down their busy brain. So they're using cannabis, alcohol, opioids to reduce the stress that they feel from this incredibly busy brain. Of course, the drugs that work best for increasing dopamine are the psychostimulants. And amphetamine, dexamphetamine, methamphetamine is prescribed in the US. Any stimulants that increase dopamine will provide some relief in ADHD. The problem, of course, is that most of our clients have difficulty getting their dose right. So Laura now comes to you having had her last discharge from hospital after another admission for psychosis. And your referral from the GP lists drug-induced psychosis, borderline personality disorders, bipolar disorder, and query schizophrenia. But now that you're thinking about things differently, you've decided to screen Laura for ADHD. And she scores 16 out of 18 on the screening scale that I showed you before. You talk to mum and you find the supporting evidence from school reports and family and friends that suggest that this could be the correct diagnosis. So Laura started on treatment and she's referred for ADHD coaching. These are the three things that actually matter. There is medication that makes a difference. I would go through a similar sort of presentation with Laura so that she understood what I was telling her about this diagnosis. And if she was in a position to afford it, there are ADHD coaches who will provide very basic information about how Laura could change her life to deal with the fact that she has a neuroatypical brain. One of the things I say to the Lauras of this world is not that your brain is abnormal, it's just a little different. And I tell this story. I say, well, supposing that we are starting a new village and we're handing out the jobs. And one of the jobs is to take the goats to the top of the hill and sit with them all day and talk to them and then bring them back in the evening. And the Lauras of this world will look at you like you've got two heads and say, oh, if one of the goats was cute, I might talk to that, but I don't care what happens to the rest. One of the jobs we're handing out is planting the corn and watching it grow. And Laura looks at you and says, no way, not doing that. One of the jobs we're handing out is to catch some brumbies and train them and organise the defence of the village. Yeah, that sounds like me. So the Lauras of this world need to be busy. And as long as they're busy enough, they're happy. They just don't like sitting in classrooms. So back to one of the real people that Laura's based on. When I met Laura, she had started many courses and failed all of them. On treatment, I got a phone call last year from a very excited young lady who had finished her first course ever and has a certificate in community service. She's now working part-time, doing an online course in AOD, and is planning to move on to a bachelor's degree. Her relationships with her family have improved. And one of the really simple tests of how well we're doing is she said, I sat down and I watched a whole movie from end to end. Until she was treated, she'd never actually watched a movie. She couldn't sit still that long. So what are the barriers to helping Laura? Well, most of us were not taught anything about ADHD. I was never taught anything about ADHD. I have done a large amount of self-education. I've been to conferences. I have some wonderful colleagues who've taught me lots. One of my colleagues has started a training course for psychiatrists and has now got a group of psychiatrists who've been really well taught. There is a lack of community resources, some of which I find really extraordinary. For most doctors, you need a psychiatric opinion to get a permit to prescribe psychostimulants. As I've said to the Drugs and Poisons Regulation Group, I find this extraordinary. It's almost impossible to kill someone with lisdexamphetamine or long-acting methylphenidate. It's pretty easy to kill people with methadone. And there are lots of other drugs which are not regulated, painkillers, for instance, which are really dangerous and lead to lifetime difficulties. Here's a group of drugs that can change people's lives, and we spend far too much time regulating their use. So we have a problem getting opinions. I'm talking to you today from Shepparton. It is extraordinarily difficult in the country to find a psychiatrist who will give you an opinion on ADHD. Even in Metro Melbourne, the number of psychiatrists who will treat ADHD is small, and the number of adult psychiatrists who will treat someone who has ADHD and uses drugs is even smaller. There are some wonderful ADHD coaches, but unsurprisingly, they'd like to be paid, and there is no rebate for ADHD coaching. So what can you do? You obviously care enough about AOD issues to put up with listening to me. There is ADHD Australia, which is a consumer organisation. It represents all of the interest groups in ADHD. If you want to know more, there is the AADPA, the Australian ADHD Professionals Association, which links people who have an interest in this. There are some great websites. My favourite is totallyadd.com, but there are lots of others. And there is a network of ADHD coaches who will provide fantastic real-life advice to your clients. The only problem is, of course, that's not paid for, so they need to be in a position to pay, you know, $90 or $100 a session to the coach. So there's a very quick overview of ADHD and alcohol and drug use from a very biased perspective. I'm now going to wander down the chat.
Thanks, Ed.
And yeah,
there's a number of while you do that, I'll give you a hand as well. There's a whole lot of questions and certainly a lot of comments, which I think is a credit to you, but also a credit to the relevance of this topic to our audience. Can I pick up on one around trauma and the difference between ADHD and trauma presentations?
I think there's a huge overlap. One of the people who's in the ADHD interest group in Melbourne is a Viennese-trained psychoanalyst, and he's very, very clear that there is a strong link between ADHD and trauma. I mean, I think the ADHD neuroatypical brain is without question is partially genetic. There's a strong family link in ADHD. If you're talking to someone with ADHD, you'll almost certainly find other members of the family who've got the problem, or their children have been diagnosed. But there's no question that trauma makes it worse.
Okay, thanks, Ed. If a young person is using heavy amounts of cannabis but feel that they have traits of ADHD, is it not possible to make an assessment of whether they have ADHD until the person is abstinent or ceases using drugs?
No, just go on with the diagnosis. And
Great.
I really get I really get frustrated by the people who advocate, I can't do anything till this person stops using drugs. Well, people are using drugs for a reason. I mean, it's one of my favorite teaching slides is around asking that question: why does this person use drugs? There's a famous quote from Russell Brand: drugs and alcohol are not my problem. Reality is my problem. Drugs and alcohol are my solution. And I think that, to say, look, I can't treat this person till they stop using, I think that's one of the great myths of AOD. If you don't do something about the underlying problem, the person's not going to stop using, because it's the AOD, it's the alcohol or other drugs that are making them feel better. Can I make a comment that how I'm really impressed at the people who've been brave enough to talk in the chat about their own use of psychostimulants and their own diagnoses? I think that's really nice.
And there's a question related to that from Jade, in fact, around a way, and I think the cartoon slide talks to this, but a way people who don't have ADHD can experience what it is like to understand what that might be like for the individual who does.
Yeah, I'm not sure. That's a really interesting question. Maybe someone who's I plead guilty of the fact that my family think I have ADHD. Maybe someone who's been more troubled by it in their life than I have, with more creative juices than I have, could be a great little movie. I'll throw that challenge back to you.
Okay, thinking then about drugs, you've touched on cannabis and Laura's use of cannabis. What about other drugs? There's a question from Christine around other drugs that clients who have ADHD use, because I think it is also associated with methamphetamine.
Well, the obvious one is meth.
Yeah, sure. Can you talk to that?
And you get that subgroup of people whose use of meth is quite different to their peers. I had a young lady in Shepparton who, much to her parents' disgust, moved in with a meth dealer. And she would describe all these people around her using huge quantities of meth and doing whatever you do when you're using huge quantities of meth. And she sort of said they were weird. I'd just have a puff and I'd feel much calmer, and then I'd do the housework, and have another puff and I could do the shopping. And it's really common to have people, with that sort of description, that, whilst the people around them are having the stimulant effects and getting excited on meth, they're going to sleep. One of my older patients said to me, this is a lady who accepted the diagnosis in her 50s. And she said, when I was young, I used to yell at dealers saying, why are you giving me this crap? It doesn't do anything. And everyone around me was excited, and I'd go to sleep.
Just returning to or staying with the AOD for a moment, how can clinicians best advocate if there's a barrier with psychiatrists or treating professionals who will not look at this until the AOD use is stopped? Is there language that can be used to support advocacy or literature?
Yeah, look, I think that, and look, it's partly, I think we've got an educational issue here. As I say, my colleague Peter Heffernan has started educating psychiatrists. He started an ADHD interest group in the College of Psychiatry last year with a handful of members, and nationally it's now over 800. So, we're doing our best to raise awareness, and there is a small group of us who are really interested in this interface between ADHD and alcohol and other drug use. And you've obviously got an idea of how I would push that barrow, that this is a group of people who deserve to be treated properly. and therefore deserve an early diagnosis and recognition that you know, the treatment will actually help the drug use. That, you know, these are people self-medicating. They may have chosen the wrong drug, and they usually get the dose wrong. But if you treat the underlying problem, then you know their alcohol and drug use will get better. Just like people who are depressed or have you know episodes of bipolar disorder and treat their mania by drinking vast amounts of alcohol, and they will get better if you treat the underlying problem.
We might wrap up shortly because we'll go to Cameron Francis in a moment. But what about misdiagnosis, Ed? Can you touch on that at all?
Yeah, I guess that there are a couple of things. You know, what are the common misdiagnoses? One would be that the person actually does have bipolar disorder, and you know, treatment with stimulants might actually trigger a manic episode. But you know, these are pretty safe, mild drugs, you know, and you know, if the diagnosis is right, then people will get almost instant improvement. You know, with some of the drugs like the antidepressants, you wait weeks to find out whether it's going to do anything. With the psychostimulants, you know, 20 minutes, 3/4 of an hour, you know whether people are getting a positive effect. So you know pretty quickly, you know, this has been a fantastic improvement in my life. Wow, for the first time I feel organized, I can concentrate on things, I can watch a movie, I can sit in classrooms. And if you've got the diagnosis wrong, then the psychostimulants won't help, and they might even make things worse.
Thanks, Ed. We really appreciate that. We've got really and unfortunately too many questions to get to today, and to get
that just means I was stirring on a good subject, doesn't it?
Well, absolutely, and I think it's reinforced and supported by our audience who recognise and acknowledge what you've said in the clients and consumers they see. So I think that's an important point as well. Can I just ask quickly, slides? Ed, would you be comfortable to make your slides available?
Yeah, sure.
Okay, great. And Julia, I'll ask you to make a comment on that in a second. But let me remind our audience that it'll be available. This is being recorded and is available on VADA's YouTube channel as well. Julia, did you want to say something?
I did. I just had one more question, excuse me, for Ed, which is I'm able to save and capture most of these questions that haven't been covered in
Do you want to just bring your microphone down, Julia? Sorry.
There you go. Can you hear me now?
Yeah, better.
I'm happy to save all of these questions that are in the chat in the Q&A. If I sent those over to you, Ed, would you be possible to maybe answer some of those, and we could provide some of those answers
Sure.
with the other resources as well?
Sure.
Perfect.
We might have to invite you back as well at another point, Ed, given the chat's gone off, as they say, or the questions.
Yeah. Well.
Any last comments from you before we thank you?
No, I just, as I say, I was really keen to sort of raise this because it seems to me that the more I learn about ADHD, the more I recognise that there's a lot of people that we've missed and may not have offered the best treatment to. And, you know, that means that there's an opportunity for us all to do better. And yeah, look, there are several people I would suggest to get back who could expand on this for you, or you know, produce a panel that you could throw questions at.
Thanks, Ed. Well, I think overwhelmingly the answer to the questions that you posed in the title of your presentation are yes, that our audience recognises the symptoms and the syndromes.
Yeah, I saw that. That's nice.
Thank you, Ed. We really appreciate it.
My pleasure.
Thank you. That was lovely. So what we will do now is take a short break, and come back in a little under 10 minutes and welcome Cameron Francis and have the second half of our winter webinar dedicated to novel psychoactive substances. So we'll see you again very shortly.